Hi, I'm Dr. David Miller with OrthoVirginia, and welcome to our Facebook Live. For those of you that don't know about OrthoVirginia, we're the largest multi-specialty orthopedic practice in Virginia. We have offices in Richmond, where I'm at, Northern Virginia, Lynchburg, and Virginia Beach. I don't want to spend a lot of time talking about OrthoVirginia, but if you want more information about us, please feel free to visit our website, which is www.orthovirginia.com. The reason we're here is a topic that is near and dear to me, and it's what to expect with total joint outpatient surgery. First, let me just tell you a little bit about myself. I told you I'm an orthopedic surgeon in Richmond. I'm at the office at Chippenham of Boulder's location. I grew up about 30 miles south of here in a place called Hopewell. I went to University of Richmond. I then went to Georgetown Medical School, and to pay for medical school, I took an Army scholarship. So I did my internship in Hawaii, Tripler, Hawaii of all places. I was a flight surgeon for 3 years, and I deployed to Desert Storm at the time. I then came back to Walter Reed, where I did my orthopedic training. And I've been back in Richmond since about 2000 actually. And my practice is pretty much exclusively joint replacements, hip and knees. And so I got interested in doing outpatient surgery over the last year, and there's a lot of reasons for that. And I started slow, and certainly we've perfected the system, and it's gotten to the point that it's a lot more common, and I'm pleased with it, and I think the patients are too. I haven't had to return anybody back to the hospital doing this. I think there's a lot of good things that happen. Those are ease, cost, quicker recovery and outcomes, pain relief. And all of these things are very important when we're doing surgery. So when I talk about outpatient surgery, I mean performing either a hip or knee replacement or a partial knee the same day. So generally it is you come in early in the morning, we get you set up for surgery, you have your surgery, and we do it pretty much early on so that you have time to recover, time to get up with therapists and get up and downstairs and go home. And if you haven't seen the Facebook Live on the surgery center, you feel free to go look at that. I actually show the facility. And so ease is a very important part about doing, outpatient surgery. It's easy to get to. You get registered, your loved one goes back, or you go back, and pre-op, and you go, and there's an operating room, and you come back around the corner, and your loved ones can come pick you up and take you out. And there's an awning underneath, so it really is. You don't have to fight or deal with the parking situation, because it's a very stressful day to begin with, and that makes it better. The cost is significantly lowered by doing it as in an outpatient setting, and that's important. The insurance companies like it because we have really good results. In the fact that there is a quicker recovery. We now know that the earlier we get you up, the earlier we get you moving around, that you avoid some of the big risks that you have with this type of procedure, being blood clots, pneumonia, pulmonary embolus, all the things, urinary tract infections we've taken care of now that we're not using Foley catheters anymore. So you have the surgery, you go out the same day, you're up and downstairs. Generally, you're driving in 2 weeks when I see you back, and that's because that's when I see you back. And then everybody wants to know about work. And today, work is different for some people. If it's a heavy workload, then anywhere from 6 to 8 weeks. But if you just generally have a stay-at-home job where you're on the phone and thinking, then it's whenever you don't need pain medicine. We've done a really good job at controlling pain because we're doing it as an outpatient procedure. We have a pain protocol, and with the pain protocol and then the blocks that we do prior to surgery, we have been able to reduce our narcotic use by approximately 24%. So that's that's something that's exciting. I think that we are getting to the place where this is more common and more accepted. And quite frankly, over the last 2 years with the pandemic, a lot of people aren't interested in getting anywhere near the hospital if they can avoid it. Now, certainly, if you need that type of care, then I would definitely do that. But in this case, we're able to safely do outpatient surgeries at our outpatient surgery center here at the Boulders, across from the Chippenham Hospital. Before we jump into any questions that you might have, don't forget to let your friends know and family if they you're interested in this topic that we had today. You can check our Facebook Live page online. Again, that's www.orthovirginia.com. So I'm sure you have a lot of questions to ask, and I want to save time for that. So feel free to ask questions, and we'll relay them on.
All right, thank you, Dr. Miller. So who can have an outpatient total joint replacement?
The patient that is best suited for it is the ones that don't have what we call a lot of comorbidities, meaning a lot of other disease process. In other words, you got your heart and your lungs are fine. You don't need renal help because your kidneys aren't working well. And it doesn't mean that if you have diabetes or high blood pressure or some other things that is doesn't preclude you from having surgery, but some of the things that we might need an internist involved in, or if you got such brittle diabetes that we need somebody to follow that after the surgery, then that might be a patient that's more suited to do it inpatient wise. But otherwise, a lot of patients are being able to done as an outpatient these days.
Thank you. How long does the surgery take?
So the procedure, I will meet you prior to the procedure, and we'll go over everything. We'll sign the site. You'll be able to talk to the anesthesiologist. You'll also be able to talk to the nurse who's going to be with you during the procedure, and we go over everything. At that time, then your family member that's with you needs to go back and either wait out in the parking lot in their car. Some like to do that, or in the waiting room. I can either meet you back there, or I can give you a call. And then the surgery itself, once everything's set up, takes me less than an hour to do. So it's important to have a procedure that's done relatively efficiently, but done very accurately, because the longer everything's exposed, the more risk there are for infections. So I like to make sure that we get things done rather quickly so that we can avoid those complications.
Thank you. What kind of anesthesia is used?
So we do, often in the hospital, we do some multimodal pain modalities, but we generally use spinal anesthesia. The problem, we don't do that as an outpatient, because if we were to numb your lower extremities, it would take sometimes hours and hours for that to come back. So in addition to doing a preoperative medication and narcotics, some steroid and an anti-inflammatory, generally Tylenol, we use a lot of Tylenol. You'll take some of that beforehand, the night before. And then we do a lot of specific blocks to help numb the area up to make it more comfortable after surgery. And some of those are more of a regional block that will wear off. But anyhow, it just makes it a lot easier. We'll also do things like inject numbing medication around the incision to help you there as well. Anything we can do to make the pain more tolerable. The worst is the first day or so, but we try to avoid that with the blocks.
Thank you. What is the recovery like? Do I have physical therapy?
Yeah, so again, I do hips and knees. Hips tend to require less therapy than do knees. So we will have it set up so you can schedule to get to outpatient you have outpatient therapy. We have found that other studies have shown that actually doing it in an outpatient setting where you actually have equipment is better than having therapy come to your house, because they just don't have the equipment they need to help you get moving. Yes, the therapy is important, but we oftentimes with hip we don't use it as much as knee. Knee, we need to get the motion that we want to get out of it. So that's important.
Thank you. Two related questions. Somebody asks, do I need to have someone stay at my house with me in the beginning? And someone else says, if a patient lives alone, how much in-home care should they arrange after a hip replacement?
So yeah, the problem with in-home care is that they're only there for a couple times a week for an hour. So it's advisable it's more ideal to have somebody that can be with you for the first week or so, or at least around, or at least available. I think that's probably the safest thing to do. As far as having individuals come in, unless they're an attendant, they're really not there that much to make a big difference.
Thank you. Can you have bilateral knee replacement as an outpatient?
We have not done that as of yet. The requirement for doing both sides like that, bilateral meaning both your knees at the same time, we haven't gotten to the point that we use that routinely. So if we're talking about doing both at the same time, then I'd probably stick towards doing it as an inpatient.
Thank you. How long after you have the surgery before you can go home? So what's the time afterwards in the surgery center?
So we'll generally I'll generally do 4 in the morning. So the first surgery starts around 7:30. You can expect to go back and have your therapy. That patient might either get home around noontime, and then an hour for each one of those after. And it might be a little earlier, a little later. It just depends on how well they're doing, how well they're waking up from the anesthesia.
Thank you. Someone says, I have a bed that I have to step up onto a step before I can get up into bed. Is that going to be okay after an outpatient replacement?
So you have a tall bed. I would probably make sure that you have some sort of a stool that you can get up on easily to get to your bed. It just makes sense.
Thank you. Do previous surgeries, such as a tibial osteotomy, make outpatient surgery not practical for a full knee replacement?
I would say that, yeah, certainly prior surgery makes things a little more difficult. But for the most part, that wouldn't preclude you from having an outpatient procedure. No.
Thank you. If somebody already has a knee replacement and it's wearing out, can you do a revision surgery as an outpatient?
Yeah, again, that would depend on how much of revision that we're doing. If it's generally exchanging the plastic on the inside, that's simple. That's probably easier than actually doing a replacement itself. If we're talking about patients that have loose components that need big revisions and stems and things, we might consider that to be more of an inpatient, but it would depend on each individual patient, yes, and their problem.
Thank you. What approach to the hip do you use for your outpatient hip replacements?
Good question. I again, if you saw my Facebook Live where I went through the operating room, one of the things that I show is the actual table that I use, which is the direct anterior approach. I'm a fan of that approach. I have been for a long time, for a lot of reasons. The bottom line on it helps me in making sure that I can accurately do the leg links. We talk about a lot of things, muscle sparing and all that, but in reality, I'm not operating through the muscles that you tend to walk with. And if you read the studies, about a year out, it probably doesn't matter which way you went. However, early on, it's easier for the patients to get up and move because I'm essentially not operating through the gluteus maximus or the buttocks muscles, and those are the ones that you use to walk with. So I do a direct anterior approach.
Thank you. Does the total knee replacement address torn ligaments in the knee?
Yeah, so things that, that the most of the torn ligaments that we talk about when we're doing that are the anterior cruciate ligament. That ligament is the only ligament that we routinely remove when we do a knee replacement. So the answer is no. I mean, if there's some ligamentous issues, we're generally able to take care of them by doing a knee replacement. And it wouldn't change whether that's as an outpatient same day or if it's in the hospital.
Thank you. If you've had steroid shots and filler shots in your knee, how long before you can have a knee replacement?
My protocol is the filler shot or the rooster comb or the gel injection or whatever you refer to it as doesn't preclude very much time. But the steroid in and of itself, I'd like to wait at least 3 months before I consider that.
Someone asks, I have lymphedema below the operative knee that needs total replacement. Does the higher risk of infection preclude me from being an outpatient?
No, but I'd have to assess that to see how bad I thought that was. Certainly, lymphedema can be a problem, but it doesn't preclude you from having surgery. No, and doesn't preclude outpatient, depending on, as long as the skin looks intact, and I'm not too worried about it. Yeah.
Is there anything that I can't do after I have a knee replacement, either right away or long term?
Well, right away depends on your range of motion and your ability to get back to either where you were, oftentimes better than you were before surgery. There are some patients, although they can, if they feel well enough to kneel on it, they can. Some people don't like to kneel on it because of the scarring or the scars there. That's why I try to put my scar off to the side a little bit so you don't kneel on it. Generally, I tell patients to stay away from high impact type activities. Doubles, tennis is okay. Anything where your foot's connected to the floor, the pedal where you're not, that's fine. Running, there are people that do that, but I want, if I do a knee replacement on you, I want to make sure that you maintain that for the rest of your life. I don't want to have to, nor do you want to have to go back and have something done over again. Most of the people that I do knee replacement surgery on weren't running prior anyhow. It's just too painful.
Thank you. Someone says, I live in a neighboring state. Does recovery not near you make follow through and therapy elsewhere difficult?
So if you're out of state, that doesn't preclude you from having surgery in Virginia, or we just have to take some, we just need to make sure that we're on proper anticoagulants and that you're able to get therapy that you need. I certainly, if I'm the surgeon, I certainly want to keep in contact with you, and I'd like to see you back at the 2 week, then 6 weeks after that, and then if I can, I'd like to see you back at the 1 year follow up if everything's going well. So.
Thank you. How long will a knee replacement last, and how long will a hip replacement last?
Generally, we talk about the same time frame for both of those. At this point, I'd say about 15 to 20 years, assuming that we avoid the complications. The complications be infection, bleeding, loosening, or early on stuff that could happen. But for the most part, 15 to 20 years, that's based off what we did 15 to 20 years ago. So it's hard for me to say how long with the newer plastics and the newer ceramics and things that we're using will last. I think that they'll last longer. I'll be dead or retired before we figure it out. So it's the way it is.
Thank you. How long does the actual hip pain continue after surgery?
It varies with patients. Okay. Oftentimes I'd like to see them back at 2 weeks in less pain than they were before they came in with their pain. It's hard to determine where that crossover is going to be. There are some people that can have some residual pain. For instance, you might have something called greater trochanteric bursitis. The healing process, if you've ever had a cut or scar or an incision, if you look at that, it stays purple for about 6 months. Then when the purpleness goes away and it turns white, then we know that's how long it takes, what we say, collagen to anneal. That's how long it takes. Even if you had an ACL and you were a professional football player, it would be till the following year till you're back doing that high level activity. So, if you're a golfer, I'd like to see you golfing, by 8 to 12 weeks. Certainly we'll get you up walking right away. And it could take six months, even a year, you can still have some healing going on. So.
Thank you. I have lots of stairs to get into my home, which is a split level, so there's a lot of stairs within it.
Yeah.
Will that be okay when I get home from surgery?
It should be okay. I think that if you have the opportunity to have something on the first floor, that'd be ideal. But you're not alone. There's lots of patients out there that have to manipulate stairs to get where they need to get to the bathroom. The bathroom or their bed. So no, that doesn't preclude any. It doesn't certainly preclude outpatient surgery. There's not much difference between that and having it done inpatient wise. So.
Thank you. Are there maximum weight limits for outpatient surgery or maximum BMI?
Yeah. So yes, our cutoff for having joint replacements, whether you have it done as an outpatient or an inpatient, is a BMI, which is a height weight ratio of 40. So you want to make sure that you get your BMI to 40 or below. And there's good reason for that. We know that the complication rate goes up precipitously after that. And not only is it good for the surgery, but it's good for you. You'll feel a lot better. And that comes from personal experience. Over the last 4 to 5 years, I have myself taken off approximately 40 pounds. And I can tell you, I feel so much better than I used to. I've stopped taking my medication that I had to take. So life's too short, and getting the weight down is important. And it's important to have your knee or your hip replaced. And our cutoff is 40. I'd like to see it lower than 35, if we could. But I promise you'll end up feeling better. And the way to take it off is diet control, right? And it's not really a diet; it's a lifestyle change. Exercise sculpts your body, and we all need to be able to walk and do things. So all those things are important. But there is a cutoff, and the BMI is 40, and you can figure that out. You can go and look online. There's calculators for BMI. And it's a height weight ratio.
Thank you. After surgery, when can you fly, and what are the risks of flying?
The risks of flying are developing blood clot. Okay, and it's not really the blood clot it's the pulmonary embolus that could happen afterwards. Now, certainly when I was doing surgery out of Walter Reed, a lot of my patients would come from a long distance, and they would fly. If we can avoid flying, that's what I would recommend. I myself, to this day, when I fly, even though I have no risk factors, I'll take a baby aspirin twice a day for a week or two before I take a long flight. Probably not a short flight, but anything that I'm going to the West Coast, I would consider doing that, just because if you notice when you fly, you get a lot of edema in your legs. So the things that you can do is, take if you can tolerate taking aspirin is fine. There's other things that you can take. Keeping your ankles moving, keeping the blood flowing, getting up, moving around a little bit. Those are all important, but surgery, this doesn't preclude you from flying if that's necessary. We just avoid it if we can.
Thank you. I had knee surgery 10 months ago and still have pain when I try to kneel. What can I do?
One of the things you can try to do is desensitize the scar. In other words, kind of sort of rub it a little bit, and then slowly work it and wear some knee pads. But quite frankly, there are patients that no matter what you do, don't like kneeling on it. I start resurfacing the kneecap behind the kneecap. I found that it hasn't been a problem for me. There's less complications, and so I like not to resurface it because I worry less about things like kneeling. But kneeling should be okay as long as you can tolerate it. And I would just desensitize the scar. 10 months isn't a long time. It seems like a long time, but there's still some hope with that.
Thank you. How long must pressure socks be worn after surgery?
I have mixed emotions about pressure socks. If they're well fitting, in other words, if you put the pressure socks on and they don't indent around it, because then it acts like a little bit of a tourniquet, then I'm okay. The problem with the off the shelf one that you buy, they don't fit very well, and then you have to get fitted ones that are expensive. You go to a prosthetist that will fit you with that type of a. So I think that if you're up walking, that's the most important thing. If you're doing your ankle pumps and keeping the blood flowing and you're on your anticoagulant, whatever's been prescribed to you, that's and the whole bottom line, the reason for doing this as an outpatient is I want y'all up moving as soon as you can. That means that day. So.
Thank you. How long will you be doing the physical therapy after surgery?
That depends on the patient. So I generally, again, hips don't need it as much. With a total knee, I'd like to see their range of motion get to at least 120, but that depends on what their preoperative range of motion is. So we know that those have a better preoperative range of motion tend to have better postoperative range of motion. I like 120 because at 120, you can generally do just about most of the things we do in life. Certainly if you get a little bit more than that, then that's great. I'm happy to see that. How long that takes, you might expect it to take up to 8 weeks. If it's getting longer than that, then we're getting to the point that it's sort of getting scarred in, and then we might need to change the course after that. So.
Thank you. Someone says, I had a total knee replacement 4 years ago. All the hardware is still good, but my soft tissue, like my quad and quad tendons, are still tight no matter how much therapy and stretching I do. Any suggestions?
Yeah, so after about 3 months, the therapy and such for stretching and getting range of motion back is pretty maxed out. You scar in after that. And then at that point, if you're still having it 4 years down the line, then I'd recommend you go back in and see your orthopedist to see if there's anything additional. Is he unhappy with the motion? Just doing some basic tests to make sure everything looks okay. And yeah, I see patients back for that sort of thing all the time. And so it's hard to answer that question without examining it and doing lab work and x-rays to see what I think is going on.
Thank you. Someone says, my doctor said he will have me use a DVT pump for 2 weeks post-op after my total hip replacement. Is this normal?
It's becoming more standard care. There are now pumps that you have at home, and I think that's the mechanical pumps are a perfectly reasonable way to go, and I think that's fine.
Okay, thank you. Somebody says, are you specifically talking about hip and knee? What about shoulders?
Yeah, I'm talking about hip and knees because that's what I do. So I long ago stopped doing shoulder surgery, so I'd leave it to those subspecialists. But we are doing, yes, and to answer the question as far as we are doing outpatient shoulder procedures as well, to include replacements.
Thank you. Are there less invasive procedures for patients with lymphedema, other than a total knee replacement?
So, first of all, we do everything we can to avoid surgery, right? And but the size or the nature of the incision isn't changed because you have lymphedema. I like to treat the soft tissues friendly so that we don't have as much fluid or problem. But no, it doesn't change how I do my procedure if there's lymphedema.
All right, thank you, Dr. Miller. That's all the questions that we have time for today. Would you like to close?
Yeah, I mean, I want to thank you for taking the time to listen to this. Again, if you have family or friends, go onto our website and see what there are, and talk to your physician, whether, you're in Northern Virginia or Lynchburg, or to see if there's, if this is an option for you there. I do feel very confident it's the way to go. And it's a safe way to go. And the earlier we get you up out of bed, walking and moving around, the better you're going to do. And you're going to have a quicker recovery and you're going to be happy for it. So thank you for your time.